I am Dr. Driscoll. Thank you, Dr. Cobbs, for the kind introduction, and thank you both to Dr. Litvak and Dr. Cobbs for inviting me to speak at this. So the talk that I'm giving today is about the updates in the histologic and genetic diagnoses of primary brain tumors. Let's see if I can figure out the clicker. So really what I'm going to do is hopefully shore up a bunch of information that's been trickling through about the various genetic tests that have been added to our brain tumor panels over the years. And we had a recent update of the WHO book. In 2016, this book was released. And it really has started to classify tumors more on a genetic basis rather than simply a morphologic basis. And so we still use morphology as our main launching point to figure out how we test our tumors, but we really are getting into more specific diagnostic categories based on what the molecular results show. And so I'm just going to walk through the basic things that we order on our glial tumors because that's a big chunk of what we do in neuropathology, and then talk about a few of the major updates in terms of some of the new diagnoses as well as how things like medulloblastoma are now classified. And so these are the objectives. You guys all have them in front of you. But really the overview of what I'm going to talk about is really going to be two parts of this talk. So the first part, like I've alluded to already, are the primary glial tumors and genetic mutations that are commonly found in those. And that's, again, a big part of what we do. So these are our astrocytic tumors, as well as our oligodendrogliomas, and then talking about the integrated diagnoses, and that's really been the big shift in what pathology has brought recently to the field of medicine, and then talking about our newly recognized diagnoses, how we were able to split off diffuse midline glioma from our malignant glial tumors, and then also the genetic classifications of medulloblastomas. And so our primary glial tumors, I get the tissue, and these are the things that I see under the microscope. On the top right, that's what an oligodendroglioma looks like. On the bottom, that's what an anaplastic oligodendroglioma looks like. We start to see vascular proliferation. And then we have our astrocytic tumors. So a diffuse astrocytoma or an anaplastic astrocytoma will look like the top left, and then glioblastoma in the bottom left. And so, I still look at the slides and figure out what do I think is going on, and how can I approach the testing to this tumor to sort everything out? And so, we have three broad categories that we can lump our primary glial tumors into, and this is a pretty standard panel of testing. 1p19q co-deletion we don't do on everything, but we do a bunch of this testing on all of our tumors. So just to kind of walk through this, we'll start with isocitrate dehydrogenase. So the first question is, why is this even important? And this is a common mutation in our low-grade tumors, so diffuse astrocytomas as well as anaplastic astrocytomas and our oligodendroglial tumors. And really fast, if there's not a reference on the end of the slide, the information I've pulled came from the WHO book, so just so you guys know too. But IDH is important because it's commonly mutated in a lot of our lower grade glial neoplasms. And then we have to ask ourselves, what does this do? And where in the cell cycle is this impacting a tumor and potentially being a driving mutation or a confounding mutation that causes progression of a tumor. And so isocitrate dehydrogenase is an enzyme that's found, it's part of the Krebs cycle, and there's a component of it that's within the mitochondria as well as within the cytosol, and it converts isocitrate to alpha-ketoglutarate normally. And so in the mutated form, you get dihydroxyglutarate, which is considered to be a mutant protein, and we're actually still kind of sorting out exactly the function of this protein in how it's regulating and impacting tumors and driving them. And studies have shown correlations that when you have this metabolic byproduct, that there are changes in DNA methylation as well as histone methylation patterns. And so it's altering the transcription of these tumors in different ways. And there's still some research going on trying to sort out exactly the role that IDH plays in driving tumors. And so on my end of the spectrum, this is IDH1 is an immunohistochemical stain. IDH1 is mutated roughly in about 80% of tumors. There are also mutations in IDH2. You saw that there's also that isoform as well. And so this will pick up about 80% of our tumors, and it has this brown cytoplasmic staining. So when it looks like this, it's positive, and then negative would be blue. And then we kind of have an algorithm that patients roughly under the age of 50, if this is negative, we reflex it to a sequencing test. So we actually have lots of modalities that we can test for these various mutations. And the reason this is important is because when you plot IDH mutated tumors versus wild type, there's a marked difference in the survival of these patients. Additionally, patients that have IDH mutations in their tumors have been found to be more chemosensitive and radiation sensitive as well. And so this has a lot of clinical implications for treatment, as well as the conversation that the clinicians have with their patients about expected survival and tumor recurrence. So the next thing that we look at primarily in the younger population, so our oligodendroglial appearing tumors as well as our diffuse astrocytomas, is 1p19q co-deletion. The first test that we use for this is a FISH test, so fluorescence in situ hybridization. And so we have probes that attach to a certain DNA sequence, and we look for losses or gains. So on the right is 1p, so you can see if you only have 3 signals in the cell, one of the green signals is lost, so that's a loss of 1p. And on the other side, the bottom left is a representation of the 19q. There's a loss of the red signal there. And so this is what we see under the microscope and can diagnose whether this is present or not. There are various sequencing assays that can also pick up gains and losses within the DNA as well. But this is the first test that we use to detect that. And so why is this important? So this was actually a major update in the WHO book in the 2016 edition. So if you do not have co-deletion, you do not call it an oligodendroglioma. One of the things historically was the category of oligoastrocytoma, and it's still a chapter in the WHO book, but our society is recommending moving away from using that diagnosis. They're calling it an exceptional diagnosis and saying that irrespective of mixed or ambiguous histology, you should really think twice about using this. And so at least the way that I practice is if the 1p19q is co-deleted, I'll lump it into an oligodendroglial tumor. And if it's not co-deleted, even if 1p is deleted but 19q isn't, it's going to be an astrocytic tumor, because they've actually found when you plot out the survival curves that even if it's like 1p is deleted, those tumors will act more like astrocytic tumors in terms of tumor progression and survival. So that's really one of the big criteria, and it's also lumped into, when I get there, the integrated diagnoses that we put on the line. So astrocytic tumors oftentimes show polysomia of this too, and so it's like, if I see polysomia of 1p and 19q, that'll also help me lean towards calling it an astrocytic tumor rather than an oligodendroglioma. So the next thing, ATRX, this is one of the newer tests that have been added to the panel of glial tumors. And this is a protein that works in, it's part of a DNA protein binding complex. And when it's retained, the tumor actually is considered wild type. And when it's lost, it actually has implications in chromosome remodeling and DNA methylation and gene expression. And so there is dysregulation of the DNA apparatus that is somehow interacting and driving tumors to progress. And there was a study, I didn't show it here for the interest of time, in knockout, so it was a rodent study with knockouts for ATRX, and these mice were predisposed to developing brain tumors. And the researchers actually demonstrated that the mice with the brain tumors that had loss of ATRX were much more chemosensitive, with a very significant reduction in the tumor burden compared to the ATRX wild type. So we tend to see these in the younger population. So ATRX mutations are much more common in pediatric gliomas, so diffuse midline gliomas, what we call them now oligodendrogliomas, and medulloblastomas. And so again, when I see this under the microscope, the picture on the far right, that's what a retained ATRX looks like, or wild type. We see it's a nuclear stain because it's part of a transcription factor. And then our ATRX mutation or loss of staining is demonstrated over here on the left. And all of the blue cells in there are tumor cells, and you might say, well, there's brown staining in there. Those are all lymphocytes within the tumor. So you have to also be able to, step back and say, what's staining, what isn't, and sort that out morphologically too. So thankfully for me, morphology is isn't out the window. And then moving along, MGMT promoter methylation. I think that this is one of the most important tests that we perform on tumors. And I think that this will have really large implications in the future for how the insurance companies dictate how the patients will be treated and things of that matter. So what is this one? And this one's actually a really interesting function as well. So 6-methylguanine DNA methyltransferase, or MGMT, is an intrinsic protein that we have in our bodies. And what it does is it reverses alkylation at the 6 position of guanine, so at a very specific site. And when that promoter is methylated, you have decrease or even absence of that protein, and replication is halted. And so there was a really wonderful New England Journal paper that demonstrated this very well. So this is an example of what this looks like in a wild-type tumor where the promoter is not methylated, the gene is transcribed, and when you introduce an alkylating agent, we use temozolomide commonly in the US rather than that agent, and MGMT will come in and remove that cross-link. And what you effectively have is a chemo-resistant tumor. When the transcript is methylated, you don't have expression of the gene, and then when you introduce alkylating agents, you don't have that protein to come in and remove that link. And so that introduces chemosensitivity to the tumor as well. And so a lot of studies have actually shown that when you have MGMT methylation, not only are these people a lot more sensitive to chemotherapy, but they're actually even more sensitive to radiotherapy as well. So when you can hit it from two angles, you actually have a significant reduction in tumor burden, as well as an increased amount of time between recurrence of tumor and then also an increased survival. And I think that once the insurance companies start to really take a look at all of these expensive tests that are being performed on tumors and, making clinical decisions saying, well, if this is methylated, go ahead and give these patients chemotherapy. But if it's unmethylated, if it's wild type, why are these people getting drugs that aren't going to impact the tumor? And currently, it's my understanding that in Europe, that's kind of the standard of care, and we're kind of catching up on things in the US. But patients who have, wild-type MGMT are just getting radiation only, and I think it's really a matter of time before that starts to change in the US. And so the reason that this is significant is that there, again, is a really striking difference between patients that have methylated and unmethylated tumors in terms of disease progression and survival. And then, so that brings us to EGFR amplification. I would say MGMT and EGFR have really been introduced for quite a while. I think EGFR has been ordered on tumors since roughly about 2008, 2009. A lot of the assays were really robust enough to come into clinical production. And so these have been performed for quite a while. And amplification is detected roughly in 40% of primary glioblastomas. Interestingly enough, patients that start out with a lower grade astrocytomas like diffuse astrocytoma or anaplastic astrocytoma, when their tumor invariably progresses to glioblastoma, oftentimes, we consider that a secondary glioblastoma, and oftentimes their EGFR is not amplified. And these are still things that they're trying to sort out of why this happens or doesn't happen. This is important because it's a potential drug target. We use Avastin to treat patients that have EGFR amplification. And this is what it looks like on our FISH probe. So we can, again, do this by fluorescence in situ hybridization. It can also be detected by various molecular NGS panels, sequencing panels, looking for amplification and increased copy numbers within that area of chromosome 7. And so I couldn't find a good survival curve. So this is actually unpublished data here. It was part of a data set that I was working on in fellowship. This was the raw data, so this isn't the prettiest graph, but you can see at about a year, the graph starts to split apart, that there is a survival advantage. And ironically, patients that have non-amplified tumors live longer. And there's a lot of debate in the literature about whether Avastin actually works. It's kind of a mixed bag right now. Some studies show that there is a marginal survival benefit, but a lot of studies are showing that it's not necessarily as good of a drug for preventing tumor progression as we thought. So there's a lot of work being done on that to try and sort out what's going on. We have a drug that specifically targets this region, so why isn't it working? So there's still more to come on that, but when EGFR is amplified, these patients tend to have a lower survival. And then finally, to kind of loop together this category, NGS gene panels and other genetic testing modalities are one of the really big game changers to this field. So I pulled this off of the Foundation One website, and as you can see, there's a rather extensive list of genes that are tested for, and it's really kind of phenomenal what we can do, that with a very small amount of tissue, we can explore a lot of different genes. And these panels can be both good and bad. They can show us really interesting mutations that these tumors have, but you always have to ask yourself, if I'm going to order this and something comes back abnormal, what am I going to do with that information? And I think that that's where we're really struggling right now clinically, is that, you can find these, we'll often call them variants of unknown significance, primarily in brain tumors, because we're still collecting data to try and figure out what the significance of various mutations are. And I think that in the near future, it's kind of this balance that, we have to do these tests to find the mutations, but, how do the clinicians explain this to the patient? Like, you have this mutation, and there may not be a drug to target it yet. So that's kind of a hard talking point to, try and sort out what's going on. What's been interesting is the hematopathology people have really been leading the field in a lot of the molecular diagnostics. And if you think about it, blood's a pretty easy sample to get, or bone marrow biopsies are relatively easy to get. And what they've actually been able to do is track the progression of tumors over time. So you can actually look at relative percentages of mutations within the tumor cells, and you can better identify the founder mutations. There will be a higher percentage of those mutations in all of the tumor cells, and then as the tumor evolves, it starts to pick up more and more mutations. And so I think that this is where these NGS panels will also coincide with what we'll be able to determine clinically. Is you can see how these tumors mutate, and then I think that we can start to address different targets as we find these tumor progressions over time. And I think that ultimately, years down the road, we'll quit classifying tumors like glioblastoma and oligodendroglioma, and even things like breast cancer, melanomas, things like that. And I think that we're actually going to be moving towards just a molecular classification of tumors as we sort out what's really going on with all of these. And so the last part of this section of my talk really are the integrated diagnoses. So this was one of the big changes in our 2016 WHO book, and Dr. Bratt was one of the really big leaders in our field. He spoke several times at our yearly meetings about really trying to incorporate these and working with our clinicians in terms of including all of the molecular information in the diagnostic line. This is really important, one, because patients can move around from institution to institution, and these reports are really complex. And so if you can communicate with our other colleagues at institutions, or even with our own colleagues in oncology and such, to say, this is what the tumor is, and here are all of the tests, the molecular tests that we performed on this, whether they're mutant or wild type, just to kind of give our colleagues an idea of what's going on molecularly with this tumor, and how do they expect this to behave. And so these are some examples of how these have been integrated. And this is always kind of a moving target for us, because our immunostains can come back in a day or two, and we can get that read, interpreted, and signed out. But our things like MGMT methylation, it's a PCR assay, and so that takes a few weeks for it to come back. And so we're still kind of even struggling on how to include as much information as possible, but also give a patient a diagnosis in a timely manner. And so I've moved towards this paradigm, and I think that the field is moving that way as well. And so just to quickly touch on some of the newly recognized diagnoses, diffuse midline glioma was really one of the big deviations that we had in our update of the WHO book. Previously, these were just high-grade gliomas in the midline, but they've actually found that there's a very specific mutation on the K27M point of histone 3, And then I'll talk about that in just a moment. And then medulloblastoma has really been parsed out into a lot of different classification or genetic classifications. And so first, diffuse midline glioma. Invariably, this is a high-grade glioma, so a WHO grade 3 or WHO grade 4 tumor. And it affects children far more commonly than it affects adults. But I would also argue to an extent that children have been the population that have been studied the most. And I think that we're going to start seeing an uptick in these diagnoses in adults as well. And so these tumors occur along the central part of the neuraxis, so involving the brainstem, the thalamus, and the spinal cord. These invariably have a very poor survival. And part of this is, the question is it the tumor? Is this a more aggressive tumor than, say, a glioblastoma or an anaplastic astrocytoma? Or is it just due to the location? Because you're really knocking out a lot of core functions in your neural system and how it works effectively. And so diffuse midline glioma is characterized by a heterozygous mutation in the K27 histone coding genes, and this is something that affects DNA synthesis and transcription. And so 80% of these mutations are in the H3 spot, and roughly 20% of them are in the H3.1 position. And so I think that this is illustrated well by a few cases. So anytime we see a tumor that's arising in midline, I will always order this stain just to evaluate for the possibility of a diffuse midline glioma. So our first case is a 54-year-old gentleman who presented with memory issues, and his wife endorsed that he has been dragging his right leg a bunch. And then the other case is a 67-year-old man that had sudden onset of right-sided weakness. And you can both see that they have lesions within the basal ganglion thalamus. And it's always hard to sort out, where did the tumor originate? And so on both of these cases, they were biopsied. And so the 54-year-old man, his path is on the left. So we see a cellular tumor with some proliferative vessels. And then the 67-year-old gentleman has what looks like a glioblastoma. But we're obligated to do this stain to try and sort out what's actually going on. And so the 54-year-old gentleman, his stain is on the right, and you can see positivity, brown staining within the tissue, and the 67-year-old gentleman does not have any staining in his tissue. And so we ended up diagnosing the patient, the 54-year-old man, with diffuse midline glioma, H3K27M mutant, where the other case was called a glioblastoma because of the absence of staining. And so that's really a pretty cut and dry diagnosis. It's easy enough to make. It's a really easy stain to interpret. And then it helps change the conversation that the clinician's able to have with their patient about what everything means. And then medulloblastomas are really the last major category to have undergone an overhaul in the new 2016 WHO book. And so there are several categories that have been teased out of all of the information that's been gathered. So we have our WNT activated groups, SHH activated groups, and then we have groups 3 and 4 that fall into neither of those. And so our group 3 and 4 are actually the more common medulloblastomas, accounting for roughly 60% of all medullos that are seen at the time, of histologic diagnosis. Group 4 is still the most common, and chromosome alterations such as copy number alterations in chromosome 17 are still the most common finding in that subcategory. And then our SHH activated groups, as well as our WNT, have kind of a split of how many patients we see. And then our SHH group is further divided into P53 mutants and wild type. And so I promise I will not go over every single one of these boxes in excruciating detail. But medulloblastomas are still kind of a mixed bag. And again, morphology, at least for me, isn't out the window. And we're still approaching these tumors by age and gender, and just based on the age of the patient when they come in and present, we can actually have some sort of predictive barometer of which way this tumor may be going. And there are actually still some morphologic variants that exist within these tumors that can also help us figure out which way to go for testing on this. And then this is the really complex part here. I'm not going to go over all these, but they're finding that there's a really mixed bag of mutations, amplifications, deletions, and point mutations that are still occurring in these tumors. And so this is also an area where our NGS panels are going to be really, really helpful. I don't know if there's any institution yet that has a specific medulloblastoma panel, but when I was in training, I had several clinicians call and ask, I have a medulloblastoma. How do I work this up? And I know that there is a lot of interest, at least in the neurosurgery, neuropathology, neuro-oncology world, about having one test that we can go to really sort out what's going on. Because even though we have, this distribution of age and gender, not everything follows the book. We'll always have, a person who's in adulthood that'll have a WNT activated tumor. I mean, these things just happen. So that's really been one of the major changes. When we have a medullo, we look for certain mutations to help classify it in different ways. And this kind of brings it back to, why you guys are all here today. So, what are the roles of surgery as well as clinical management of these tumors? So in terms of things like medulloblastoma, it's been really interesting to go to the neuropath meetings because some of my colleagues are working on rapid diagnostic tests. So, in the neurosurgeons resecting this tumor, we get it frozen and say, this is, some sort of malignant small round blue cell tumor. We're looking for a fast test to really help, say it's probably going to be this category because as we see here, some of these ones, mainly group 4, which everyone has the poorest outcome, I forget. But anyway, so some of those, you're gonna need to do as much of a surgical resection as possible. Some of these tumors are a lot more sensitive to chemo and radiation. So they're actually finding if you can debulk the tumor and leave some of it behind, it'll basically disappear once we treat it. And so that's one of the things, at least that the neuropathologists are starting to work on to really guide the hand of the surgeon to say, resect as much as possible, or it's okay to leave some tumor behind because we'll be able to clean it up with chemo and radiation. And so I think that that's one of the big changes that'll be coming down the pipeline, but unfortunately we're not quite there yet. So I think at this time there aren't any really major changes in surgical management based on the 2016 updates. We're still kind of at the point of biopsy the tissue, do as much of a resection as possible, and then we'll sort this out as fast as we can. I think that the WHO book actually has a lot more implications for the neuro-oncology side of things in terms of chemo and radiation. I've alluded to some of this with the MGMT methylation, and I think that that'll be one of the big changes that we see. Currently, one of the limitations of MGMT is it has roughly a 30% false negative rate. So meaning roughly 30% of people that are told that their MGMT or that the MGMT of their tumor is wild type actually have mutations there. And they're actually finding that there are low levels of methylation further down in the gene. So PCR has its limitations. When you attach your primers, you may not pick up certain regions of the gene because it's a rather large gene. And so they're actually even finding that patients that have low levels of methylation are their tumors are very sensitive to alkylating agents as well as radiation. So I think that once we develop more robust tests, that test result will have more impact on patient care. And so also too, the presence and absence of mutations, deletions, and gene amplifications, as I've shown you with EGFR and IDH, really help guide our clinicians on how they can treat the patients. And then I think that we're really in a cool time for science. I mean, we always have been, but everything just keeps getting more and more fun. We're finding more mutations. We're being able to develop drugs to target these mutations and help improve the survival of patients. And one of the things that we always question, has the tumor recurred? And for example, in patients with glioblastoma, they've undergone chemotherapy and radiation. And as a response to radiation, the brain reacts and, you can get this enhancement. And the question is always, is this the response to radiation or is this recurrence of tumor? Well, when you have radiation to the brain and tumor recurrence, you also have breakdown of the blood-brain barrier because the tissue's been damaged. And this is where cell-free DNA can actually be a really amazing modality. So this is a very new technology that's being introduced, and what you can actually do is a blood draw on the patient, and then they're actually able to tease out certain segments of DNA that belong to tumor. They subtract out the patient's background, and they're finding tumor recurrences much earlier. There are a lot of developments right now for this modality in our more common tumors, breast, prostate melanomas, and things like that. But I think as we get better at determining, what are the significant mutations and are we able to find them, I think that this will start finding its way into the neuropath world as well. And so I think that that will be able to really guide our hand of, is this radiation change or does the patient have tumor recurrence? And we can pick these up much earlier and then also, get the patients back in for treatment. So this is kind of an early phase of starting on the molecular era, but I think that we have a lot of really wonderful things coming down the pipeline to hopefully improve the survival of our patients with these glial tumors. So with that, if you have any questions or comments, I am happy to welcome those at this time. I've answered all the questions.
I would just like to make a comment that I think that one really exciting thing that's going to probably happen in the next few years is that for pediatric low-grade gliomas and for IDH1 mutant tumors, there are a lot of people that are looking at ways to treat those based on some unusual BRAF mutations that those low-grade tumors have. Mm-hmm. And they might start responding to different drugs, and then the IDH1 mutants have, particular metabolic vulnerabilities that are going to be targeted. So it's pretty exciting. Thank you very much.
Yeah, I just want you to stay up here because we do have a few minutes, and I do want to encourage some conversation and discussion. And just to sort of kick things off, we have some guest faculty that are going to be speaking later, and I was just hoping maybe starting with Dr. Sinai here, and I don't want to get too much into your phase 0 talk later, but if you could sort of comment on the revolution in diagnostics. And I think that the main question is, do we even think we're going to need neuropathologists 10 years from now?
So I can take the last question first. So the answer is absolutely.
Oh, good.
Will we pay them, though? That's the problem.
But neuropathologists are more and more becoming molecular biologists. And so what we all face in the field are patients that come to us with these foundation medicine reports, Caris Life Sciences reports, and concerned family with these very loosely associated relationships between a biomarker and a drug. Most of the time, there's no evidence to actually support that relationship. So I think as a field, what we're trying to do is figure out how you make sense of all of this data and what the therapeutic implications are. This is one of the topics of my talk, but, really trying to get at the understanding of how different targeted inhibitors and other drugs are relating to some of these biomarkers you mentioned. So this is it's an exciting time, like you said, but it's also a time when we have a lot of excess information and not enough rationale to sort it out. And so that's incumbent upon all of us to take over.
Thank you, Dr. Sinai from Barrow, who's going to be speaking this afternoon. Dr. Oranger from University of Michigan. Do we or will we need neuropathologists in 10 years?
Absolutely. The role of the neuropathologist may change, though. And so, I think neuropathology a decade ago was almost exclusively built on morphologic interpretation of histology images. In the next 10 years, I think a lot of neuropathology is not going to just merge with molecular biology, but it's also going to be a bioinformatics specialty. So the histology, the morphology of these tumors is going to continue to be important, and you mentioned that too. But that will probably be delivered to you in a more quantitative way. And there will be tools, which we'll talk about a little bit later today, that will allow us to, instead of sort of getting a gestalt feel about the way a tumor looks, we'll actually be able to quantify how oligo-like or how astro-like is this, and develop a tool that has better iterator reliability than, I trained here, and this is how we call these things. And then on the molecular biology side, as the significance of this rush of molecular biology data, genomic data, sequencing data, methylomic data it becomes more clear what's relevant and what's not. the role of the neuropathologist is essential at integrating all these different data streams to come up with a classification that's accurate for the type of tumor that the patient has. And that is of extreme importance to the patient and the caregiver team. So neuropathologists are going to be increasingly important, I would say.
Okay, thank you. Rob Lewis from Hoag. Dr. Lewis, are we going to need neuropathologists in 10 years? Please say no.
I'm just a simple surgeon, so I'm going to have to say yes, because once we get into the molecular stuff, it's way over my head, and I want to be able to take it out and know what it is. So if you give me the answers, I'm good.
No, I think that, I think Nader put it really nicely, that it's changing, and the information that you are able to provide and help guide us for both surgical management and treatment is going to just be more and more important as we learn how to understand what the implications of these different genetic mutations mean. You know, we may not be relying so much on the H&E and a lot more on the molecular genomics of the cancer, and we're going to hear more about that this morning. Both from a treatment side and a diagnostic side. I think, you know, the real holy grail is getting to a point of, okay, does this person need surgery? And being able to make that decision non-invasively, so not necessarily needing a surgical biopsy up front. And then if we do take them to surgery, using that information to help guide us in the actual extent of surgery. And we're going to see a little bit later about that, about image-guided, but I think beyond image-guided is really molecular-guided surgery and really understanding where the margins of the tumor is and what we can do surgically to alter the outcome for the patient. Any questions or comments from the
I'd like
group?
to make a bold sort of prediction. I think that 10 years from now, in a general sense, gliomas will be divided into 3 broad categories: pediatric low-grade gliomas, and about 75% of those have BRAF, unconventional BRAF mutations. I believe during that time, someone's going to figure out how to target that. So that's going to hopefully provide adjunctive treatment for that 75% of low-grade astrocytomas. You know, most of those are not malignant in the terms of, you know, you die from them, but a lot of them come back, and radiation and surgery is really brutal for these kids. I think that the secondary glioblastomas and, you know, astrocytomas that are IDH1 mutant, you know, I predict that those will be followed by MR spectroscopy as an adjunct, which is an imaging study that can look at the metabolome for specific metabolic products of this particular mutation, and that there will be drugs that will be discovered that will be able to target the unique pathway that is involved in that mutation that leads to high levels of 2-hydroxyglutarate, et cetera, and changes all the methylation status of the cell. And then thirdly, I think that for glioblastomas, you know, there were a couple papers in Nature recently that suggest that, you know, much to the contra dogma that, you know, we can't find particular tumor-associated mutations or neoantigens, that if you do find neoantigens in some of these gliomas and you do stimulate with vaccines that are really robust, you can have a very profound immune response even for glioblastomas. But that's kind of a personalized treatment. But it sort of opens the window for immunotherapy as a possibility, and I'll talk some more about that. But I think that, you know, we're really on the cusp of some highly targeted molecular therapies that will make the surgeons be not so sad when they talk to patients, so they can, you know, yeah, we can take it out and then you can have this, you know. Right now it's, we'll take it out and then we can turn on the radiation machine and give you temozolomide.
All
And then
right,
you can
so,
only survive for a year.
all right, I think that's a nice transition to our next speaker. Thank you again, Dr. Driscoll.